Good morning, everyone. I still hope that you're safe, sane, and healthy. This would be the last lecture of the female genital tract pathology. Today we'll be discussing diseases of pregnancy. These include placental inflammations and infections, ectopic pregnancy, preeclampsia and eclampsia, in addition to gestational trophoblastic diseases. Infection of the placenta and subsequent inflammation arrive at the placenta via two routes. The first one is the ascending infection. This occurs through the birth canal, which is more common than the hematogenous spread. They're likely to be bacterial and could be complicated by premature birth. Histologically, the chorioamnion will be filled with neutrophils, edema and congestion of the vessels. It could extend beyond the membranes into the umbilical cord, causing vasculitis. The bacteria that can cause this include mycoplasma, bacteria of the vaginal flora, and sometimes candida, which is a fungus, can cause it. This image is of the chorioamnion, commonly referred to as fetal membranes. The upper layer represents the amnion. The lower layer represents the chorion. The very small green arrows here point at the neutrophils, which should not normally exist in the fetal membranes. Their existence implies inflammation. The other route is the hematogenous spread, meaning the infection spreads from the mother's bloodstream into the villi. These are characteristic of syphilis, tuberculosis, listeria, toxoplasmosis, rubella, CMV, and herpes. All of these cause villitis. Collectively, this transplacental infection are named TORCH, which stands for Toxoplasma, others rubella, CMV, and herpes. These are very important because they can cause congenital anomalies, ranging from structural anomalies, deafness, blindness, absent limbs, etc. Ectopic pregnancy refers to whenever the zygote implants itself outside the endometrial cavity. Most commonly, this occurs in the fallopian tube. However, it can happen on the ovaries, cervix, outside the pelvic wall, etc. 90% of them occur in the fallopian tube, however. This complicates 1% of all pregnancies. Any factor that hinders the passage of the ovum from the fallopian tube to the uterus predisposes to ectopic pregnancy. For example, we mentioned previously that pelvic inflammatory disease could result in scarring of the fallopian tube and increase the risk of ectopic pregnancy. Sometimes no cause is seen. Ovarian pregnancies result when the ovum is fertilized within its follicles without of the ova going out from the Graafian follicle. Again, this is rare compared to the fallopian tube pregnancies. Same applies to the gestation within the abdominal cavity. The problem with these is they can rupture because the space within them is not compatible with continuation of pregnancy, and the rupture could result in bleeding, which is sometimes fatal. One point that's important clinically is that the presentation of ectopic pregnancy is typically abdominal pain and vaginal hemorrhage. Sometimes there is no hemorrhage. Lower abdominal pain is very nonspecific and can be seen in ovarian torsion, ovarian cyst torsion, as we mentioned in the last lecture, ectopic pregnancy, and acute appendicitis. That's why it's very important for anyone who presents with lower abdominal pain to be checked for these disorders. This histologic image shows how ectopic pregnancy is confirmed under the microscope. We have to see fallopian tube lining, which is these fronts of fibrovascular cores covered by a single layer of cuboidal epithelium on the right side of the image, and on the left side we can see the chorionic villi, which are parts of the placenta. This is where the exchange of gases and nutrients occurs between the maternal and the fetal circulation. Gestational trophoblastic diseases are divided into 3 overlapping morphology categories. These range in aggressiveness from totally benign to highly aggressive and malignant. The Hydatidiform mole, the invasive mole, and the choriocarcinoma. In these disorders, the role of beta-HCG, which is the pregnancy hormone, is very important for follow-up of these patients, because all of these 3 disorders are characterized by high levels of HCG. So when the tumor or the disease is removed surgically, the best way to follow up is to measure the HCG. If the levels are back to normal, this implies complete cure. Hydatidiform mole is a voluminous mass of swollen, cystically dilated chorionic villi, which appear as grape-like structures. These swollen villi are covered by varying amounts of normal to highly atypical chorionic epithelium. There are 2 distinctive subtypes of molar pregnancy, or Hydatidiform mole: complete and partial. Complete mole occurs when 2 sets of paternal chromosomes fertilize an empty maternal ovum, meaning complete moles have 46 chromosomes, similar to the normal human cell. However, all of these 46 chromosomes are from the father, and the mother did not contribute any chromosomes. This does not allow for formation of fetal parts or normal embryogenesis. On the other hand, partial mole is seen when one normal ovum with one set of 23 maternal chromosomes is fertilized by 2 sets of paternal chromosomes, resulting in tridiploid chromosomal sets. This can allow for embryogenesis, and fetal parts can be seen sometimes in partial moles, but never in complete moles. Molar pregnancy is most common before the age of 20 and after the age of 40. Having a history of molar pregnancy will increase the risk of molar pregnancy and subsequent conceptions. It happens clinically. It is suspected when there is an elevation in beta-HCG, quite remarkable elevation, in the absence of fetal parts or fetal heart in the uterus by ultrasonographic examination. This applies, of course, to complete moles. The clinical suspicions for partial mole comes when the enlargement of the uterus and the elevation of the beta-HCG is incompatible with the pregnancy age. For example, if the patient is supposed to have 4 weeks of pregnancy, but her beta-HCG is compatible with 12 weeks of gestation, and her uterus size is larger than what's expected for 4 weeks, then suspicion of partial molar pregnancy should be employed, and imaging techniques and examination of the patient should be done promptly to rule out molar pregnancy. This is a schematic presentation of the chromosomal constitution of molar pregnancy. The upper half represents complete mole. As we said, there is no maternal DNA in complete molar pregnancy, and all the DNA is from the father. And the chromosomal constitution is 46 chromosomes, like the normal ones. However, they are both from the father. On the other hand, the partial mole has tridiploid chromosomes, 1 set from the mother and 2 sets from the father. This is a macroscopic image showing large chorionic villi. Normally, you should not be able to see the villi grossly without the microscope. These two images represent chorionic villi. The upper right one represents normal villi. Notice how they are small and vascular. The lower left one represents complete molar pregnancy, in which the villi are really large, edematous, and cystically dilated. Invasive mole is a term that's implied when a complete molar pregnancy has penetrated the myometrium of the uterus. It is locally aggressive but does not have the malignant metastatic potential of choriocarcinoma. Because of the deep penetration of the uterine wall, they can cause rupture of the uterine wall, resulting in severe, possibly life-threatening hemorrhages. They can locally spread, but they do not metastasize. They can embolize, which is a different term from metastasis, and I will explain that in a second. Hydropic villi of invasive mole can embolize to distant organs, such as the lung or even the brain. But they do not constitute true metastasis because they cannot grow on their own in these locations. Unlike metastasis of malignant tumors, which when they metastasize to an outside organ, for example, if the colon cancer metastasizes to the brain, it can grow within the brain tissue on its own because it's malignant. However, embolization does not offer that capability, and they always regress spontaneously in these remote locations. So they are not true metastases, they're just embolization. They're difficult to remove by dilatation and curettage. And if the lady undergoes just curettage, then the HCG will remain high because of the presence of chorionic villi within the uterine wall. So they should be treated by either surgery or sometimes chemotherapy. Choriocarcinoma is the other extreme end of the spectrum. It is a very aggressive tumor. It arises from gestational chorionic epithelium or from stem cells within the gonads or elsewhere. So we have two major types. The one that's related to pregnancy, so they appear from gestational chorionic epithelium, or the one that has nothing to do with pregnancy and occurs as a malignant tumor of the germ cells, either in the testis or the ovary. The risk is greater before the age of 20 and after the age of 40, similar to molar pregnancy. 50% of those choriocarcinomas arise in the setting of previous complete mole, 25% after abortion, and 25% after normal pregnancy. Partial mole does not result in choriocarcinoma. Presentation-wise, these women present with bloody brownish discharge accompanied by exceptionally high titers of beta-HCG. By the time gestational choriocarcinoma is discovered, it's typically widespread dissemination via the blood, typically to the lung, because lymphatic invasion is not common. However, the good news is, despite their extreme aggressiveness, even when they are metastasizing, the cure rate is nearly 100%, because these tumors respond very nicely to chemotherapy. However, the gonadal choriocarcinoma does not respond that nicely, and it's postulated that since the gestational choriocarcinoma has some paternal DNA, some DNA from the father, it can be conceived as foreign body to the patient's body, and antibodies can attack those tumor cells, helping with their elimination with the help of chemotherapy. On the other hand, the gonadal choriocarcinoma does not have that feature because it does not have any foreign DNA in it. Lastly, preeclampsia, eclampsia, collectively known as toxemia of pregnancy. Preeclampsia, is the development of hypertension, proteinuria, and edema in the third trimester of pregnancy. These complicate 5 to 10% of pregnancies, specifically the first pregnancy, in women older than the age of 35. If preeclampsia goes unnoticed or untreated, Renal function might be compromised with severe high blood pressure and seizures. The presence of seizures is the mainstay of the diagnosis of eclampsia. So to diagnose eclampsia, the patient has to have seizures. Both of these diseases are collectively known as toxemia of pregnancy, although there's no specific toxin in the blood of the patient. The problem with eclampsia, it can result in DIC, which is disseminated intravascular coagulation, in which there is widespread coagulation, ischemic insults to vital organs such as the kidney, consumptive coagulopathy with low levels of clotting factors and platelets, which predisposes the patient to bleeding. The underlying mechanism is hindrance of the maternal blood flow to the placenta, secondary to inadequate development of the spiral arteries. Recent studies have suggested imbalance between pro-angiogenic and anti-angiogenic factors. Treatment of preeclampsia is with antihypertensive medications. Once again, I would like to thank all of you for listening. Please do not hesitate to ask me any questions if you have any.